So I like this saying from Leonardo da Vinci, details make perfection, but perfection is not a detail. And I think perimetry, which is an art, is a lot about details. We have 4 versions of the MonCvONE perimeter, and last webinar I presented the clinical research version, and I may say a few words if some people want more information later on. The MonCvONE perimeter is a cupola shape. HFA doesn't have the same shape. It's an ovoid shape, which is good for the central field, but if you are dealing with a periphery, the ovoid shape may create some lack of accuracy, specifically when you do binocular visual fields. The MonCvONE perimeter is using LED illumination for the backlight as well as for the stimulus source. That's different to the HFA because the HFA is still using technologies like fluorescent or halogen or incandescent source. I don't know how these technologies, which are kind of old, meet the standards relative to ROHS or environment. So let's go step by step. The first thing when you install a patient is to occlude one eye. And the eye occluder is something important. How many of you have tested a visual field on themselves? I think it's an important experience because you will realize what patient experience after a few minutes. Usually they describe that they see the background light of the cupola going on and off. That's what's called the Ganzfeld blankout phenomenon, and it's believed to be due to a difference in illumination between the tested eye and the occluded eye. This happens in quite a large percentage of patients, something like 80% according to the literature. It doesn't happen under binocular viewing, and this creates some kind of blankout about 30% of the examination time. That's true for static, kinetic, any kind of perimetry. And it has been shown that during the blankout phase, something like 2 decibels of sensitivity loss happens for the threshold of the stimulus. So that means over the entire examination time, you will lose something like 0.7 decibels. One solution to this problem is to use an opalescent occluder, something that will maintain the same amount of light on both eyes, on the tested eye and the occluded eye. And that will improve the sensitivity of the tested eye, reduce fluctuations. On our device, we have introduced this opalescent occluder with a magnetic attachment that is useful because it somehow reduces examination time. Also, there is no contact with the patient, which may be important nowadays because of these virus problems. And also, it's a lot better for the comfort of the patient. One drawback, however, it's only occluding the central part of the visual field. So if you want to do any kinetic perimetry in the periphery, you need to use the full occluding solution. Now let's talk about the next step, which is the optical correction. On our device, we have 2 possibilities. One is to use a standard metal rim lens, and we have an holder to use that. And on that holder, you can put 2 lenses, one for the sphere and one for the cylinder. However, we also propose this large field lens with a diameter of 55 millimeters, both of them with magnet technology. We have this interface on this device, which allows you to select the appropriate correction. Let me remind you that you need to use a correction that depends on age, that depends also on the distance refraction. So the interface allows you to enter the date of birth, and you have to be careful about this because if you make any mistake, the software will not identify the birth date and consider your patient is 20 years old. If the patient is 60, that makes a huge difference in terms of correction. Then you will enter distance refraction, sphere and cylinder, and press the calculate button, and that will give you which lens is appropriate in the set of lenses that we propose. Now, let me explain a little bit more about the importance of using a large diameter lens. What happens if you use a small metal rim lens that doesn't allow much movement from the patient? So let's consider the patient makes a movement of 5 millimeter. 5 millimeter is not so much. That reduces the size of the field that you can test if you want to avoid the risk of having some rim artifact. So I made some rough calculations with a metal rim lens. The maximum eccentricity in terms of degree that you can test is something like 22.6 degrees. Whereas if you use a large field lens, it's much larger. If you make some calculations, you will find out that this is 2.5 more surface area of the visual field. That's true not only for the metal rim lens, but also for the new technology proposed by Humphrey, which is the liquid crystal lens. Now let's go to the next step, which is patient positioning. Our MonCvONE device, we have 3 positions for testing the patient. One position for the right eye, where we have a fixation dot which is 15 degrees on the left of the center of the cupola. So at the center of the cupola, we have the blind spot, and that is where we put the monitoring camera. This allows us to extend the field of vision that we can test up to 105 degrees on the temporal side. Now, if you are under binocular conditions, then the fixation dot is at the center, just above this camera, and we will be able to test 90 degrees both sides. Now, if you are working on the right eye, the fixation will be 15 degrees on the right of the center of the cupola, and we will be able to test again 105 degrees on the temporal side. You will notice that the head holder is tilting by an amount of 15 degrees when you test the right eye or the left eye. And for that reason, you need to orient the head in the direction of the fixation dot. You need eventually to adjust the position of the eye. It doesn't have to be so precise. It just needs to be within the rectangle that you can see on the video monitoring. You can adjust finally this position by using the navigation button, which is on the front panel of the MonCvONE, or eventually you can do it remotely from the keyboard by pressing the F1, F2, F3, F4 key. F1, F2, right and left, F3, F4, up and down. And that can also be a useful point because of the virus contamination problem for the technician.